Let's join Dr. David Weissmiller for a discussion on sexually transmitted infections, vaginitis and vaginosis.
And we're going to turn our attention to the ever-popular sexually transmitted infections. We're going to include vaginosis here, although it's not an STI. Since the CDC includes those, we'll include those here. Nothing to disclose still. Here are our learning objectives, and we'll begin with our first case. A 22-year-old nulliparous woman presents for an annual well-woman evaluation, and she complains of vaginal discharge for 2 days. On the pelvic exam, there are no lesions on the vulva or the vagina. The cervix appears reddened, almost strawberry texture. There's a generous amount of yellowish malodorous leukorrhea, but no notable pus at the cervical os. The bimanual exam, some questionable cervical tenderness, and there's a fullness in both adnexa. The exam is limited due to the patient's obesity. Of the following, which is the most likely diagnosis? Herpes simplex virus infection, Trichomonas vaginalis, Candida albicans, or bacterial vaginosis? Okay, let's see what we came up with. So we think it's Trichomonas vaginalis, and that is the correct answer. If we look at the other possibilities, of course, herpes tends to give painful vesicles. These can ulcerate. Candida, not infrequently, will have an itchy white discharge. BV, of course, is mixed vaginal flora. This is a shift or potential overgrowth secondary to some other issue that's going on intravaginally. You can see a malodorous discharge. They can have itching, but they typically don't see pelvic pain or cervicitis, which is going to lead us to the trichomonas. Now, keep in mind with trick, most of us are now using a liquid-based pap smear. The recommendation is if you see trick on a liquid-based pap smear, pap cytology, you should just treat. Trick on a liquid-based cytological specimen, just treat. Now, how are we going to treat it? Whether we've made the diagnosis by liquid-based pap or within our patient with the discharge. Would it be Metrogel vaginal, azithromycin, metronidazole, or levofloxacin? I'm feeling good about this. Let's see. Excellent. 2 grams orally of metronidazole is the preferred treatment. Please keep in mind that in pregnancy, in every trimester, once again, in pregnancy, in every trimester with trichomoniasis, metronidazole is the drug of choice. 2 grams orally, you can use if they're allergic, although that's uncommon, clindamycin. The alternative is to use a BID for 7 days. When you look at PO versus topical, the PO is more efficacious. Treatment failure, you repeat the oral dose. You should also treat the sexual partner. Anytime you're treating sexual partners, it should be partners with which they have come in contact within the past 60 days. 60 days. Is follow-up necessary? 2015, the CDC said retesting for trick is recommended for all sexually active women within 3 months following the initial treatment. I'm going to update this to say this is now supported in terms of men as well. So both, because of the high risk of it being passed and forth, the CDC is now saying with trick, you should reevaluate for potential continuing infection 3 months after treatment. Most recurrent infections, having sex with an untreated partner. What do we do if our failure has occurred and reinfection is excluded? So I don't think they responded to the therapy, and this is not reinfection. The first choice is metronidazole 500 BID for 7 days. If that fails, they love you. Metronidazole 2 grams a day for 5 days. In pregnancy, as we said, any stage, it's metronidazole. 30-year-old African-American female presents with a vaginal discharge, and on examination, it is homogeneous with a pH of 5.5. She has a positive whiff test and many clue cells. Which one of the following findings is this patient is most sensitive and specific for the diagnosis of BV? Would it be pH of the discharge, presence of clue cells, the character of the discharge, or the whiff test? And what did we come up with? We sought the presence of clue cells, and that is the most sensitive and specific. Remember, formally making the diagnosis of BV requires 3 of the 4 Amsel criteria. I have a discharge, which is homogeneous and grayish-white. The pH is greater than 4.5. Clue cells are present, or I have a positive amine. That is, volatilized amines upon the addition of KOH. Are expressed. Keep in mind that semen can do the same thing. However, those little buggers are running around the slide, so you will know that they are there. Keep in mind that BV is not just an annoyance ailment. There is a relationship, not cause-effect, with premature rupture of membranes, postpartum endometritis, postoperative infections, even the acquisition of HIV. Here is the current treatment recommendation from the CDC in 2015. It's metronidazole BID for 7 days. Alternatively, you can use tinidazole. If you have recurrent BV, by definition, 3 or more episodes in 12 months, you can do a trial of metronidazole vaginal gel, 5 grams, 2 times per week for 4 to 6 months. But really clearing this is very difficult, and most likely you're going to need to look at other lifestyle issues. One that is important is probiotics. Eating yogurt daily for 2 months, or you can make a vaginal suppository with yogurt. You go and buy the suppository capsule, you fill it with yogurt. It's kind of like a Pinterest project. Now, keep in mind, you do it daily for a week, you then stop it, then daily for the second week. I think it's easier just to eat the yogurt. If you're going to make the suppositories, you need to get plain yogurt. BV, does it work? Yes. Candidiasis? No. No adverse effects, though. We're serving yogurt every morning here. We could have a little project. 39-year-old diabetic female with a hemoglobin A1C of 7.4 presents to the office with an 8-day history of thick, white vaginal discharge and itching. She tried a 7-day over-the-counter treatment for a yeast infection, but admits she only completed 5 days of the therapy. On examination, you find extensive vulvar erythema, excoriations, and edema. There is a thick, curd-like white discharge at the introitus with the vagina being erythematous. A KOH prep of vaginal secretion shows budding yeast and hyphae. Which of the following medications would be the most appropriate treatment for this condition? Triconazole intravaginal, fluconazole orally, miconazole intravaginal, or clotrimazole intravaginal? Okay, and the majority of you chose B, fluconazole 150 orally in 2 doses, 72 hours apart. Let's take a look at why that is the correct answer. Well, we have uncomplicated and complicated vulvovaginal candidiasis. Uncomplicated, infrequent, typically albicans species. These are immunocompetent, non-pregnant women. Complicated is where I've got uncontrolled diabetes, debilitation, immunosuppression, pregnancy. These tend to be more severe symptoms, and they tend to be more non-albicans species. Now, there are predisposing factors. I want to point out to you the best evidence is poorly controlled diabetes, immunosuppression, and HIV. Those are the 3 which are most commonly associated. Now, what is this issue with non-albicans species? It appears to be increased when you have increased over-the-counter use of antifungal agents, but you don't complete the course. You know, you might have 1 of 3 days or 3 of 7 days. What happens is you tend to eliminate the more sensitive albicans, and you select out for these azole-resistant non-albican species. This Cochrane review from 2002, looking at how we best treat, whether it's uncomplicated or complicated. Let's start with uncomplicated. Clinical and mycological cures are the same whether you use oral or topical. Most people prefer oral. The levels of antifungal agent remain in the vagina for up to 72 hours after taking it orally. With severe VVC, extensive vulvar erythema, edema, excoriation, fissure, typically, and that's what our patient was dealing with here, you want to do a second dose 72 hours after the initial dose. Recurrent, defined as 4 specific episodes occurring in 12 months or at least 3 episodes unrelated to antibiotic therapy within the past year. You need induction therapy, fluconazole, every 72 hours times 3, or 7 to 14 days of topical treatment. Maintenance therapy, once weekly for 6 months. I have a patient that I saw about 3 weeks ago who falls into this. When I did her exam, the entire perineum was like on fire. I saw her 2 weeks later after the induction therapy. She gave me a hug. It was amazing the response that she had had. We now got to get her diabetes under control. Herpes. Most infections are subclinical or mild, a potent facilitator of HIV. The current recommendation on screening dates way back to 2002. Routine serologic screening is not recommended. Keep in mind that latex condoms are effective in preventing transmission. Most data that shows about a third of discordant couples, though, do not use them. No antibodies to HSV 1 or 2 when you have primary HSV. Remember, most of these patients are going to be asymptomatic. How do we know that? Because epidemiologically, if you look at studies where people come in and say, yeah, this is the first time I've had it, they're IgG positive. So they haven't had the primary outbreak that was at least diagnosed. Viral shedding can go on for 12 days. So what most of the time we're seeing is the first clinical episodes. These patients should receive antiviral therapy. If the healing is incomplete after 10 days, you can continue this for another 10 days. I had a young man in my practice about 6 months ago that at 10 days still had not had resolution of the lesion, so we treated for another 10 days to see that there was complete resolution. Recurrent HSV. Keep in mind that 90% of persons with primary HSV2 will have at least one recurrence within 12 months. So on the exam, if they tell you this is the first episode, and then they ask you about, what do you need to warn them about, they're going to have another episode within the next 12 months. Episodic therapy for recurrent herpes, it's good that they have a prescription at home because within a day of lesion or prodrome, you want them to start antiviral therapy. Now, one place that suppressive therapy can be helpful is the CDC recommends that you could consider it if they have 6 or more outbreaks a year. Okay, I know no patient who is going to wait to talk about suppressive therapy to get to 6 outbreaks a year. Usually after 1 or 2, they're saying, can I be put on something? It reduces but does not eliminate the subclinical viral shedding, so they still, if it's a discordant couple, should be using a condom to prevent transmission potentially. 22-year-old sexually active female comes to your office for a Pap test and STI screening. Her Pap test is normal, but she tests positive for gonorrhea. Chlamydia testing is negative. Which one of the following is the recommended treatment? Doxycycline, ceftriaxone plus azithro, or ofloxacin? Okay, I'm feeling good about this. Excellent. The correct answer is C, ceftriaxone plus azithromycin. Okay, here's gonorrhea in the United States. So the take-home message here is, for gonorrhea at any site, it's 250 of ceftriaxone plus azithro. That's why I wrote that question that way. If she happened to have chlamydia, you would also get the chlamydia. But for gonorrhea alone, it's ceftriaxone plus azithro. This is the regimen regardless of travel history or sexual behavior for all adults and adolescents. I don't have any ceftriaxone. I can give a single oral dose of cefixime plus the azithro. If they're allergic to cephalosporins, a single dose of 2 grams of azithro. Please highlight the next point. If any of the alternatives are used, that patient needs to come back in a week for test of cure. If the standard regimen is used, the patient does not have to come back in a week. If you fail to respond to therapy, the CDC says you should do susceptibility testing. i.e., you're going to be getting out a chocolate auger plate. Patients who have persistent symptoms after treatment should be retested by culture. If the culture is positive, that isolate is submitted for resistance testing. We've already said test of cure 1 week after retreatment to assure when you're dealing with this issue as well that it has been completely cleared, and you want to ensure that the sex partners from the preceding 60 days have been treated. In pregnancy, you can use the cephalosporin regimen and azithromycin regimen as well. Here's the USPSTF recommendation in terms of screening. It's a grade B. All high-risk sexually active adolescent girls and women under 25, multiple sex partners, by definition 4 or more lifetime partners. No barrier contraception, incarcerated, illicit drug use. Insufficient evidence for or against routine screening in high-risk men. They recommend against routine screening of low-risk men and women. So if on the exam she's 31, one sexual partner, that would be a low-risk individual. 21-year-old female had a pelvic exam and a normal Pap test 1 week ago. Her screening test for chlamydia returned positive. She's now being treated for chlamydia cervicitis with azithromycin 1 gram in a single dose. When should she have a test of cure for chlamydia? 1 to 2 weeks, 3 to 4 months, 12 months, no test of cure. Okay, and that is correct answer. No test of cure is required. Here's chlamydia. The only people who get a test of cure for chlamydia, essentially, is if you are pregnant. Okay, if you are pregnant, you get a test of cure 3 to 4 weeks after treatment. The exceptions would be, I don't know if she took it, symptoms are persisting, and I think she's been reinfected. Now, what everybody gets for chlamydia, and now add this, for gonorrhea and for trick. The CDC is now recommending that both men and women with any of those 3 diseases now be tested for reinfection 3 months after treatment. This has changed. So for trick, gonorrhea, chlamydia, 3 months after treatment, you should be tested for reinfection, both men and women. For chlamydia, if you're pregnant, you get a test of cure and then a test for reinfection at 3 months. For gonorrhea, you only get a test of cure if you've used an alternative regimen or symptoms are persisting. Here's the USPSTF recommendation for screening for chlamydia. It looks just like gonorrhea. Non-culture tests. We use a DNA amplification test. You can use an endocervical secretion or a urine sample. Keep in mind that a urine sample, it's a first void, not a clean catch, and preferably they should not have voided within 2 hours prior to collecting the sample. So if for some reason your office just does routine clean catches when they come in, that's an inappropriate sample to submit because there's an increased risk of a false negative. Recommended treatment, doxy or azithro. The alternatives are listed there, particularly the floxacins. Males with urethritis, the take-home is treat first and diagnose later. Treat first, diagnose later. PID, which can be a complication of cervicitis, keep in mind that this is a clinical diagnosis. You have to have these minimal criteria, which is uterine or adnexal tenderness or cervical motion tenderness, and no other cause for the illness identified. Importantly, empiric therapy will not impair the diagnosis and management. So always start the therapy as you're trying to figure out what's going on if you're suspecting this could be PID. Now, once you've met the minimal criteria, are there other supportive criteria that are helpful? Sure. Mucopurulent discharge, temperature, white blood cells, evidence of inflammation. The take-home message is it's a clinical diagnosis. How do we manage it? Start the empiric therapy. These women are at increased risk for ectopic and infertility. Keep thinking about a polymicrobial infection. Again, as with any of the cervicitis or vaginitis, we treat the partners within the last 60 days. Mild to moderate disease, I can try to treat them as an outpatient. There are 2 regimens that you can use. Do they need to be admitted? Well, sure. I'm not sure of the diagnosis. I think they might have an abscess. They look toxic. They haven't responded to therapy. I can't get them back to follow up on therapy. They don't have a way to do that. These would be the patients I would want to be considering for admission, and then these are the two regimens you would use parenterally in those who are hospitalized. HIV screening. Important to remind everyone that we screen all patients aged 15 to 65 for HIV. Please highlight, regardless of risk level. Studies from the late 80s to early 90s show we cannot predict who needs to be screened. Why do we do this now? We have convincing evidence that identifying and treating HIV infection in asymptomatic people will substantially benefit the public health. We don't necessarily know what the screening interval is. The USPSTF says it's reasonable to rescreen at risk, and some could be saying if you're sexually active, you're at risk at 1-year intervals. It's proven that initiation of antiretroviral therapy before carriers become symptomatic markedly reduces the progression to AIDS and to death. Who else needs to be screened? Younger adolescents and older adults, all pregnant women, including those that we do not know their status when they are in labor. All hospitals now need to be able to do rapid HIV testing. Why do we worry about the aging? Because the CDC has shown that in 2010, 35% of all HIV-infected individuals are older than 50. I've got a 64-year-old in my practice, HIV positive, who was diagnosed in the early 90s. This has become a chronic disease. Testing options, we really have moved to a 4th-generation screen and cascade testing, so we combine antigen and antibody, so as soon as 15 to 17 days after infection, you can find a positive test. We have to communicate results. Of course, if they're negative, this can be done over the telephone. If it's indeterminate, these should be done confidentially and in person. If it's positive, confidentially and in person, and of course, reported as a communicable disease. We have strategies for prevention in terms of pre-exposure prophylaxis to reduce the community viral load in new infections. This has been approved since July of 2012 by the FDA in terms of daily oral therapy. This does not mean, despite the overwhelmingly positive evidence we see with this, the recommendation still is you should engage in safe sexual practices. Counsel on behavioral risk modification, condom use, you got to monitor their pregnancy status and STI status. Pre-exposure prophylaxis, we still are determining how to best identify appropriate candidates. Very important is kidney function testing and regular evaluation for HIV status. Non-occupational post-exposure prophylaxis, I've come in contact, HIV testing of the source as soon as possible, initiate therapy within 72 hours, 28-day course unless the source comes back negative. According to the CDC 2015, screening for syphilis should be undertaken by which of the following tests? Dark field microscopy, non-treponemal serology, fluorescent treponemal antibody absorption test, or the Weil-Felix test. Okay, let's see what we came up with here. Excellent. The recommendation is to use a non-treponemal serology. That was answer B. Answer B. Now, whenever we're thinking about ulcers, we're thinking herpes, treponema, HSV, Haemophilus ducreyi, and you always need to be thinking HIV as well. Keep in mind, in practice and on the exam, particularly in women where you're treating an ulcer and it doesn't respond to antimicrobial or antiviral therapy, you need to be thinking vulvar intraepithelial neoplasia. Those things need to be biopsied. Okay, here's syphilis in the United States. Here's the diagnosis. Although there's a lot about treponemal antibody serology, the CDC still recommends a non-treponemal followed by the treponemal. Very important. The USPSTF strongly recommends that persons at increased risk for syphilis be screened. Sex workers, IV drug abuse, HIV positive, other STIs, so this is part of the panel, and then a known partner with active syphilis. Treatment, penicillin, penicillin, penicillin. Preferred if you're allergic, desensitized to penicillin. Limited evidence of any other regimens that are effective. If you're going to try one, it would be doxycycline or tetracycline, and you're going to need a 14-day course. 35-year-old man sees you in the office to establish care. You learn his parents were born in Southeast Asia. Although he was born in the U.S., he does not have any vaccination records from his childhood. During the visit, he mentions that a relative was recently diagnosed with hepatitis B virus infection and asked whether he should be screened. According to the USPSTF, which one of the following screening recommendations is appropriate for this patient? Screen for infection because he is at high risk. Do not screen for infection, but provide the first dose of the HPV vaccine series. Do not screen for hepatitis B virus infection because he was born in the U.S., or screen for infection because he's at high risk of developing chronic HPV infection and dying from cirrhosis or hepatocellular carcinoma. Okay, what do we come up with here? Okay, so the majority of you chose B. The correct answer is A, screen for hepatitis B virus infection because he is at high risk. Here's the screening recommendation from the USPSTF. Screening for HPV infection in pregnant women at their first prenatal visit, and they recommend screening for Hep B virus infection in those who are at high risk, including our patient, U.S.-born person not vaccinated as an infant whose parents were born in regions with a high prevalence of HPV infection. Okay, typically in any kind of algorithm where they got to work down to say, would you screen or something like that, or medication, they're going to take you all the way down to the bottom. Okay, so that's where that particular person comes in. But you can see there are other high-risk groups to which this would apply. And there is the map showing you those areas which tend to have high, intermediate, or high risks associated with demographic principles. Prevention, healthcare professionals exposed, give HBIG and then the vaccine if they've not previously had it. And it is amazing the percentage in this country of healthcare associated workers who have not had the hepatitis B vaccine. Amazing when you look at the data. Newborns and mothers infected, they get HBIG after delivery. They get started on the hepatitis B vaccine series. They're even bathed in the delivery room. Hep C. There are now more deaths in the U.S. from Hep C than HIV. Millions of people are living with this infection, and new infections continue to be reported. There is a big push right now by the CDC to look at finding these people. The USPSTF recommends screening for Hep C in persons at high risk. They also recommend offering one-time screening to adults born between 1945 and 1965. These strategies are very important, and what we're looking for is current HCV infection. We're actually having a discussion on this at our Family Medicine Update this year. We did one 2 years ago. There were no PO meds at that time. Now there are several PO meds, which means what? We're going to be seeing more of these patients in our office. So here's the recommendation in terms of the CDC. We do an HCV antibody. If it's reactive, you get an HCV RNA. If that is detected, they've got current infection, and you link them to care. Very important. And with that, that's our tripping through sexually transmitted infections. Thank you very much for your attention.